We can start. Okay. Okay. So, all right. I'll just start the video for a little while. Okay. So, good evening to all of you. So, I'm Dr. Nipunika Senadira, consultant hematologist at LRH. I'm going to discuss two hematological cases, disease presentations. So I'll share my screen now.
Excuse me, madam.
Yes.
Madam, there's some background noise
There
coming.
is background noise. Okay. Okay. I'll try. Yeah, okay. Is it okay now?
It's fine now, madam. Yeah.
Right. Okay. Okay. Right. So the first case, this is now other thing I want to tell you is now if you have any questions, like you can just raise hand or interrupt and we can discuss like while I'm doing it. There is no issue. So the first is it's a 7-month-old child who had episodes of fever and was taken to the general practitioner. And the doctor noticed that the child was very pale. And on examination, there was mild hepatosplenomegaly, but there was no lymphadenopathy. And the blood test done, a full blood count done, revealed that the hemoglobin was 3.8, which is very low. Okay, so so that is severe anemia, and this is a WHO definition of anemia. It's a condition in which there's a number of either the red blood cells or their oxygen carrying capacity is insufficient to meet physiological needs.
Madam, we can't see the screen.
You can see, okay. So I haven't. Okay, just give me a second. Give me a second. Sorry about that. Okay, right. So you didn't see the previous one, I suppose. Can you see now?
Yes, madam.
Okay, so this was a 7-month-old child who presented with severe pallor, with mild hepatosplenomegaly, and the hemoglobin when tested was very low, 3.8. Right, so 3.8 hemoglobin is severe anemia, and anemia, I just put down the WHO definition, is the reduction in the number of red cells or the oxygen carrying capacity, and which is insufficient to meet the physiological needs. And the important thing is this can vary by age, sex, altitude, and pregnancy status. So you know what this is. No, this is the hemoglobin molecule, which has 2 pairs of globin chains and the heme molecule inside. So this is what carries the oxygen to tissues from lungs. This is just to show you that the hemoglobin differs by age, and sex and the pregnancy status, but it varies between the normal range from 11 to 13 grams per deciliter. Now, going back to this child, what are the causes of severe anemia in a child? Can you think of few causes? One or two? Anyone? Anyone? The cause of severe anemia in a 7-month-old child? No? Why? Just
Iron
one.
deficiency anemia.
Very good. Okay. Iron deficiency anemia. Anything else?
Hemoglobinopathy.
Yes, a hemoglobinopathy. So those are the things that come into your mind. No? Okay. So now when we try to find a cause, when anyone, child, adult, present with anemia, there are so many causes of anemia. So it's good to have some classification in your mind so that you will not miss anything. And it's easy to decide on the investigations you would do next, right? Because there are so many causes. So we'll just, broadly the causes can be categorized as anemia due to impaired red cell production, due to increased red cell destruction, which is hemolysis, or frank blood loss, right? So this now in this child specifically, now impaired red cell production at this age, right? That can happen. That can happen either due to red cell aplasia, that is purely the red cells are not produced by the bone marrow, that is called red cell aplasia, or due to ineffective erythropoiesis. So it's produced, but they are not good quality red cells. So they are removed by the reticuloendothelial system of the bone marrow. So you don't produce, put out good quality red cells. So that is called ineffective erythropoiesis. So that's one cause, broad category. Or that can be hemolysis. There are many causes of hemolysis. You can have red cell membrane disorders, enzyme disorders, hemoglobinopathies. Hemoglobinopathies, I must say that it can also cause ineffective erythropoiesis, either hemolysis or ineffective erythropoiesis. And then immune-mediated hemolysis, the autoimmune hemolysis. Then there is another category, the blood loss. Now, fetal-maternal hemorrhage doesn't come at this age, but at birth, if there was severe anemia, you would think of fetal-maternal hemorrhage. Then chronic GI blood loss, inherited bleeding disorders, we have called chronic bleeding. So these are the broad categories, and you should have this in mind when you're thinking of when you meet a child with anyone with anemia. So what are the other causes for this? Now, impaired red cell production or red cell aplasia happens when there's parvovirus infection. That's a very common cause of acquired red cell aplasia. Then the congenital cause is called Diamond-Blackfan anemia. Then also children can have a condition called transient erythroblastopenia of childhood. The rare things are Fanconi's aplastic anemia, which usually cause pancytopenia, but they can initially present with anemia alone or malignancies. Then ineffective erythropoiesis can be caused by deficiencies of nutrients like iron deficiency, folic acid deficiency, then chronic inflammations, renal failures, not really in this child, but other rare things like the myelodysplasia, lead poisoning. And then we go to the next category, which is now red cell membrane disorders. You would have heard of heterospherocytosis or G6PD deficiencies and enzyme disorder. Hemoglobinopathies are broadly categorized as thalassemia and other variant hemoglobinopathies like sickle cell disease. And then the immune disorders, autoimmune hemolytic anemias. Hemolytic disease of the newborn, of course, happens close to birth. But any other autoimmune hemolytic anemias like paroxysmal cold hemoglobinuria, then warm or cold autoimmune hemolytic anemias can happen. And then, of course, bleeding. So these are the broad categories which you should think of when you're trying to find the cause of the anemia in this child. Now, this is just to say that, like show you that where the red cells, the blood is produced in a child, initially at birth, the whole skeletal, it's in marrow on the whole skeletal. But just give me a second. Then, but by adulthood, it's just in the axial skeleton and proximal ends of femur. Okay, this is one way of finding the cause, just to illustrate that there are many ways of finding the cause. This is by the MCV, but we'll go to discuss this later. So the investigations. Can you tell me now, this child, what are the investigations? How would you investigate? What are the basic investigations you would do?
Full blood count with red cells.
Yes, very good. Full blood count.
And blood picture.
And blood picture, yes. Now, this a child with severe anemia. So you have all those things in your mind, and you want to narrow it down. So you will do a full blood count. Why do you look at now we know the hemoglobin. Now, what else can you find out from the full blood count to give you a clue about the anemia, the cause of the anemia?
And we can look at the red cell distribution data.
Okay, you can look at the red cell indices, no? And red cell distribution, which is one of the indices. You would want to look at the MCV, MCH, and the red cell count. Then it will tell you whether it's a hypochromic microcytic red cells, macrocytes, or normocytic normochromic. Okay, so full blood count gives those information. And then what about the others? Then the white cell count, platelets, you would want to say whether they are normal, no? We only know the hemoglobin. We would want to know whether the other things are also affected. Whether the other parameters, whether it's a pancytopenia, we don't know. We only know the hemoglobin. So whether the WBC, the platelets are normal. Then what else? You said blood picture, no? So you would want to look at the morphology of the red cells. Then what else? Then what else? Any other investigations you can think of?
Reticulocyte count.
Yes, very good, very good. So reticulocyte count. What information does that give?
Red blood cell,
Yes, it will tell you whether the marrow, the activity of bone marrow, no? Because there is anemia. When there is anemia, you expect the bone marrow to produce more cells as a response to it. So now, then, if it is not there, we want to know whether the normal marrow response is not there or not. If there's a defective marrow, there will not be any response. Okay, so whether it's high or low. What else? Okay, I'll just go on. Right. So these are the ones I would think of. So the full blood count, a blood picture, a retic count. Then now, why do we do a direct antiglobulin test or the Coombs test, direct Coombs test? In which condition does that become positive?
immune-mediated hemolytic anemia?
Yes. So that is one of the differential diagnosis. So you would want to do a Coombs test, and then serum bilirubin, LDH, urine urobilinogen to see whether there is hemolysis. These are all to see if these will be in high or urobilinogen low, high when there is hemolysis. And then, of course, the baseline biochemistry. So these are the initial tests I would like to do. Then I just want to show you this count. This is actually this child's full blood count, right? Can someone just quickly tell me, otherwise we are taking long time, just quickly tell me what you see in this. Someone?
There's a very high WBC count with the low RBC count.
Okay.
And the low hemoglobin with the very low hematocrit as well.
Yes, very good. So you notice that the white cell count is very high, and there's a severe anemia with hypochromic microcytic red cells. Right. Okay. Now this is the child's blood picture. Another one. Quickly tell me what you see in this. And can you see why the white cell count was very high? What are these cells that you see here? What are these cells? Can you guess what these cells are?
Blast cells, sir.
Pardon?
Blast cells?
No, they are not blast cells. They are actually nucleated red cells, what we call NRBCs, right? So these are nucleated red cells. They're all new. This is a lymphocyte. Okay, this is a lymphocyte. These are all nucleated red cells. You know the red cells before they. Now this is a polychromatic, right? The reticulocytes, when you see in the Leishman stain, we call them polychromatics. They are because they are bluish purple color. And then this is the stage just before that. Usually they are not seen in the outside in the peripheral blood, but they are in the bone marrow. But when there is some reason, they are also pushed out of the marrow prematurely. So they still retain their nucleus. Right? They're usually pushed out after taking off this nucleus. So this is a nucleated red cell or a NRBC. Right? Okay, so these are also nucleated red cells, a little earlier stages of NRBC. So that is the reason why in the hematology, in the analyzer report, the white cell count was very high because these red cells contain nuclei. They were counted as white cells. Right? All the nucleated cells are counted as white cells. So that is why the white cell count is high. But in modern analyzers, some analyzers, they are calculated. They are counted separately. So even if there are nucleated red cells, they are counted separately. They are not counted as white cells. But in this instance, they were all counted together. So what about the red cells? Can you see that they're hypochromic microcytic, and then there are target cells? Can you see there are target cells? There are these cells which we call irregularly contracted cells. Okay, and basically it's a hypochromic microcytic blood picture. Okay, so these are reticulocytes, right? Reticulocytes. This is the Leishman stain, the normal stain we put for blood picture, and this is the special stain. It's called, right, with the new methylene blue, and you see it's a supravital stain where the blood films are not fixed, and these are the reticulocytes where the remnant RNA material are stained. So these are counted and then given as a percentage. This is just to illustrate the direct antiglobulin set or the Coombs test. Okay, so the Coombs test detects red cells which have antibodies attached to them. So what we put from outside are antibodies that will bind to the antibody-bound red cells and cause agglutination. So it detects already antibody-bound red cells in the patient's blood. Now this hemoglobin, right? Hemoglobin quantification is the next step. Now we have a hyperchromic microcytic red cell, blood picture, which is what does that favor from all the diagnosis, all the possibilities, with a very high nucleated red cell count outside.
Hemoglobinopathy.
Yes. So that picture is very typical of a thalassemia. Okay. So then when you see that picture, so you are quite the high on the possibilities is a hemoglobinopathy, a thalassemia. So this is just to tell you, remind you. I'm sure you have studied this, how the globin chains are developed in the from the fetal life. The alpha chains are produced from the beginning, but in there are two clusters, alpha-like and beta-like. In the alpha-like, it's the alpha chains that are produced, but beta chains are start producing later on in life. Earlier, it's the gamma chains. So alpha-2 and gamma-2 together are hemoglobin F. So by birth, the predominant hemoglobin in a baby is hemoglobin F. But by about 6 months, the beta chains predominate, which is the adult form of hemoglobin, alpha-2, beta-2, which is HbA, right? So by about 7 months, that age of this baby, the baby should be having a predominant HbA and a little low amount of HbF, right? So that is what we would expect in this baby by this age. Okay. So this is just the same thing. So HbF level goes down by about 7 months, and HbA is the predominant hemoglobin with a little bit of HbA2 as well. So this is this child's hemoglobin quantification report. What does it show? It shows predominant HbF. 95% is HbF with a little bit of HbA2 and very little Hb adult hemoglobin, which means the child is not producing adult hemoglobin as the child should by this age. So there is a problem in the hemoglobin production. That is a beta chain production. Are you with me? Do you understand?
Yes, madam.
Okay, right. If any one of you didn't really get it, you can ask me, right? I can explain again. So because beta chains are not produced, you can see because HbA is very low. We would expect about 70-80% of HbA by this age, but it's not there. That is because now the beta chains, which should be there for adult hemoglobin, is not being produced. Therefore, it is compensated by HbF. So it is still being produced just to compensate. Now, how do we confirm? Now we think this is beta thalassemia, homozygous beta thalassemia. Now to confirm, the final confirmation is by genetic analysis, but there is another way of finding it out. I mean, further confirmation is by doing the parent screening, hemoglobin quantification. If a child is to have homozygous beta thalassemia, both parents have to be beta thalassemia carriers. So the mother was, this is the mother. Mother has beta thalassemia carrier status diagnosed by high HbA2 level. In beta thalassemia carriers, HbA2 level is above 3.5%. So it's so in the mother. So mother is a beta thalassemia carrier. And this is the father. Father is also a carrier. So both are carriers. So it is possible for the child to have homozygous beta thalassemia. Okay, right. So just quickly, beta thalassemia is a syndrome. It's a spectrum of diseases, starting on one end with the mild carriers, thalassemia carriers, to the other end, transfusion-dependent thalassemias. Okay. And in between, there are thalassemia in the intermediate category where they will need transfusions, but they're not transfusion dependent. They might need intermittently to when there is anemia. So thalassemia is associated with many complications, and management of it. So the complications are mainly due to so these children are dependent on the blood transfusions, so they can have complications related to blood transfusion. Initially, if the blood transfusions are not done properly, complications related to anemia like hepatosplenomegaly, frontal bossing due to extramedullary erythropoiesis, hemophilia, and then the other thing is when blood transfusions are happening, iron can be accumulated in the body. So all complications that can result from iron deposition in organs, liver, heart, and endocrine organs. So that will lead to endocrinopathies like diabetes, hypothyroidism, so on. So management is involves, firstly, after diagnosis, counseling the parents, because this is a lifelong disease, a chronic disease, which will affect the whole family. So counseling, then of course transfusion of red cells, and they usually need transfusion about 3 weeks, either 3 or 4 weekly. Then after about 10 transfusions, or by about 2 years, we need to start iron chelation when the serum ferritin level is above 1000. Then, of course, the management of complications of chronic anemia, multiple transfusions, iron overload, and then when there's iron overload, you give iron chelators to remove iron. They also have certain complications. That has to be managed. Another mode of management is splenectomy, which is not very favored nowadays because it is involved with many side effects like severe sepsis, risk of sepsis, and thrombosis. And the definitive management cure is by bone marrow transplantation. When the diagnosis is made, transfusion is initiated when the hemoglobin is less than 7 on 2 occasions, 2 weeks apart, or if there are significant symptoms of anemia, poor growth, or failure to thrive, and complications from excessive intramedullary hemophilia, and or significant extramedullary hemophilia, like frontal bossing and hepatosplenomegaly. So these are the criteria to initiate transfusion therapy. But in these patients, once you initiate, you will have to continue transfusing. So the red cells should be leukoreduced and ABO, rhesus, and KEL matched. So before the first transfusion, it is very important that we do a extended red cell phenotyping. And we should give fresh blood, like at least 2 weeks after collection. And then the main thing is to maintain the pre-transfusion hemoglobin above 9 grams per deciliter. If we do not do that, there's a risk of progressive hepatosplenomegaly. And then higher target for those with cardiac disease, and post-transfusion hemoglobin should not be more than 14 or 15 grams per deciliter. So, as I said, there can be a lot of complications associated with transfusions, the usual complications, and chronic complications are the most important thing, that is iron overload. That is the main problem in managing thalassemia patients, accumulation of iron. And for that, iron chelation is started. So before iron chelation was available, most patients died of due to iron deposition, especially in the heart. But the problem is compliance in the children. So there are 3 chelators, that is desferoxamine, deferriprone, and deferricirox. So desferoxamine is the parenteral drug, which is given either as an IV infusion or subcut infusion by a pump. And deferriprone is not very much used now, but it is a good drug. We now mostly start the first line drug is deferricirox or Asundra. So as I said, the definitive diagnosis is by bone marrow transplant, and for thalassemia patients, it's usually the stem cell source is bone marrow. So it's by doing a bone marrow harvest from a matched donor, and then the collected harvest, the stem cells are infused to the patient after conditioning, like a blood transfusion. So that is what a bone marrow transplant is. Okay. So bone marrow transplant is the treatment of choice for transfusion-dependent thalassemia if there is a matched sibling donor, because the success rate of such transplant is more than 90%. But the success rate reduces when the child is older, or the iron overload is one of the major factors that will affect the outcome of transplant. So quickly, the prevention. So this is a very difficult disease once you get it. So therefore, but it can be prevented. Preventing is because it can be prevented because the carriers can be detected. Unlike in many diseases, in thalassemia, the carriers can be detected by a simple blood test. That is a full blood count, and if there's a hyperchromic microcytic indices, we can do a hemoglobin quantification, and just by seeing the elevated HbA2 level, thalassemia carriers can be detected. So there is a national screening program that is going on, and when the counts are normal, they are issued with a green card, and when the HbA2 is high, when the carriers are detected, they are issued this pink card. Okay, so that is that patient. So I went a bit quickly to finish it by half an hour. But is there anything? If you have any questions, if there's anything you didn't understand, you can ask now. I can't see you all.
Excuse me, madam.
Yes.
Madam, is there? I met a patient that he has started without trying the oral deferricirox. He started with desferoxamine straightly. Is there a specific indication that to start not trying the oral one and going for the parenteral one?
When that is when you are initiating iron chelation, is it?
Yes, ma'am.
Well, when the counts are the level is very high, it's very difficult to control with deferricirox alone. You will have to have some parenteral iron chelation on also with it to achieve a control. So that could be the reason. I don't know. You said that there was a patient, who was started on parenteral.
Yes, madam. And he was at home also. He was having the parenteral injections, that subcutaneous.
Yes. How old is this patient?
1 year and 7 months.
Yeah. What was the ferritin? Can you remember the ferritin level?
Initially, it was 1200. That's why he was started on.
Yeah. Other thing is the liver functions. Was there a problem with the liver functions? If there is, then it's a bit difficult to start. That could be another reason why that was started, because the control of iron is quicker with this feral. So sometimes when it's Asundra is, compliance is better because it's oral, but there are times, many times we have to combine both together to get a good control. After achieving a control, we can, change, like, give monotherapy with the oral one.
Okay, madam. Thank you.
Right? Okay.
Okay.
Any more questions? Right. I'll move to the other patient, right? Because, yes.
How can we differentiate alpha thalassemia minor from beta thalassemia treatment?
Okay, right. Good question. Right. The indices are similar. You get hypochromic microcytic indices just like that in both. And like if I just go a little bit beyond that and say that how we would differentiate with iron deficiency, it also has hypochromic microcytic indices, but here in thalassemia the red cell count is normal or high, right? And the MCHC is usually normal. So in both alpha and beta, coming back to your question, they are similar. But in alpha thalassemia, when you do the hemoglobin quantification, it's normal. You don't see this high HbA2 level. It's normal. So when we have ruled out alpha iron deficiency and the indices are like a thalassemia tray, when we do the hemoglobin quantification, if the quantification does not show is normal, does not show elevated HbA2, we suspect alpha thalassemia. But there is no way of confirming alpha thalassemia by hemoglobin quantification. Then the confirmation is only by doing genetic testing, molecular analysis, right? But having said that, it's not done routinely because alpha thalassemia is not as much as a problem as beta thalassemia. Because alpha, there are, can you remember, there are 4 alpha genes in our chromosomes. So, missing one, so alpha, the syndrome, alpha thalassemia, now we are worried about beta trace because 2 beta carriers can cause thalassemia major. But alpha is not like that because there are 4 genes having alpha transfusion dependent alpha thalassemia is very rare. Okay, in our country, and because of the positioning of, if I go, I might complicate you, but we have to know is in Sri Lanka, the prevalence of alpha tray is quite high, although we don't detect it because we don't have a simple test to do it, but it is not a clinical problem because we don't have, it doesn't cause transfusion-dependent anemias. Okay, so therefore it's not a big issue in that sense. The problem we have is beta thalassemia.
Thank you.
Okay, right. So I'll move on to the other case. It's a different topic. It's approaching a child with bleeding. So it's an 8-month-old child who presents with swelling of a knee joint. The history reveals appearance of ecchymotic patches on skin on and off since birth. Just give me a second. And so what are the information would you try to gather from parents? Sorry about that. Okay. So what are the, now in this child, what other information would you try to gather from parents? Can someone tell me? Child with swelling of knee joint, and there are some bleeding patches had on and off since birth. You're there? Anyone?
How it progress, madam? When did the first notice whether they are
Okay,
associated?
oh, very good. Yes, yes. How it progresses. Now they say they had been there from, from birth, they are one on and off. They have noticed bluish patches in the body.
The family history, the associated
Yes,
spontaneous.
yes.
So,
Yes, family history. Yes, that I also thought so. So you think about now we have skin bleeds. They talk about skin bleeds and a joint bleed, and then we want to know whether there were other type of bleeds about vaccination, whether there was hematoma formation, epistaxis, hematuria, other forms, and then the family history of bleeding disorders. Okay, the family history. Okay, so now we would want to do a bleeder screening in this, like like the previous child we were doing the anemia screening. No, so here a bleeder screening. So what are the tests we do for our bleeder screening? What are the tests we would do? Tell me one or two tests that we do for the bleeder screening. When you encounter child with bleeding, what are the tests that are done?
Full blood count.
Okay, very good. Full blood count for what?
To say the platelet.
Yes, to see the platelet count, right?
And clotting profile.
Okay, what involves the clotting profile?
Um,
You have to, like, we can't say clotting profile. We'll have to ask for specific tests. That now, of course, now when LRH, the bleeders are referred and we, do the clotting test, the profile. But then tell me what are there in the profile?
PT, APTT.
Yes, prothrombin time, APTT, bleeding time. What else?
INR.
INR is in the prothrombin time, no? It's one way of expressing the prothrombin time is INR. What else? Anything else? You're right. Any more tests for the basic bleeding screening? Pardon?
Tourniquet.
What is that? Tourniquet? Are you referring to the bleeding time? Or are you referring to that, what we do for dengue?
Yes, madam.
That is the one. No. That, of course, is, yes, it's a screening test for dengue. No, it's not done for, bleeder screening.
Madam, inhibitor testing.
We wouldn't think of an inhibitor, no, when a child presents initially with a bleeding symptoms. Not in a child, actually. Adults can have acquired inhibitors and can present, the initial presentation with bleeding can be due to inhibitors, but not a child. Okay, so, right.
We can check the factor levels, madam, factor 7.
Yeah, but I wouldn't do factor levels as the basic screening, right? Because then if you jump to factor level, you might miss a platelet function disorder, no? So first we have to do the basics to find where the problem is. We don't know whether it's a factor problem. So we would do what we call the bleeder screening. So bleeder screening involves a full blood count and a blood picture, a prothrombin time, APTT, thrombin time, plasma fibrinogen, a bleeding time, and a clot solubility test. And why do we do all this? To get an overall idea about what what is happening, where the problem is. Now you, I don't know whether you know about the clotting cascade, don't you? You have heard about it. No, the intrinsic, extrinsic pathways, the common pathway. Have you all studied that some time ago? I'm sure you have, right? So this is all that together, and the way it really happens in the body. So you have these platelets when some injury or insult to the vessel happens, when we say we knock ourselves or something happens, the platelets are there, and the platelets are activated and tissue factor are generated. So this tissue factor activates factor 7. Okay, activated factor 7 activates factor 10, the common pathway, right? When factor 10 is activated, it turns prothrombin to thrombin. So this thrombin which is generated then, so this is the initiation phase. The thrombin which is generated will activate factor 9. This is the amplification phase. It activates factor 9. Which in turn activates factor 11. And then again, this pathway goes on. So this is the amplification pathway. Tissue factor is only required for the initiation, but after that, this is the loop that happens, and more thrombin is generated. Thrombin will turn fibrinogen to fibrin, and fibrin will cross-link, is cross-linked by fibrin. The fibrin is cross-linked by factor 13 and made into a stable clot, with measures the red cells and the platelets, and all together it forms a fibrin clot and prevents bleeding. So this is the clotting pathway. So we do all these tests to find where the defect is when a patient is bleeding. So whether it's a platelets, whether it's a problem in the intrinsic pathway, whether it's the extrinsic pathway, or problem in the intrinsic pathway, or the common pathway here. That's the thrombin type. And then clot solubility test is done to check the factor 13 deficiency. And plus a fibrinogen level to find whether the fibrinogen is normal, level is normal. Okay? Okay, so now this child, no, we can't be talking of all the diseases, so I thought, okay, now this child we found that has a isolated prolonged APT, that is only the APTT is high, and all other factors are normal. The platelet count is normal, prothrombin time is normal, fibrinogen is normal, only the APTT is prolonged. So what are the causes of high APTT? So APTT is in the intrinsic pathway. So what are the factors that can happen that affect APTT? Any idea? You want to go?
Hemophilia A and B.
Yes. So what are the factors? Factor 8 and 9. So intrinsic pathway factor 8, 9, 11, 12. So deficiencies in any of the factors can cause prolonged APTT, but factor 12 deficiency does not usually cause bleeding, right? And then also these, in any inhibitor to the factors in this pathway can also prolong APTT. It can be either specific factors like acquired factor 8 inhibitors, usually doesn't come in children, we see it in adults, or lupus anticoagulant. When lupus anticoagulant is present, it can inhibit this the coagulation factors and cause prolonged APTT. But it doesn't cause bleeding. So it's not very relevant in this situation, in this patient. So now what are the other tests? Now when we see a high APTT, the next step we do is something called 50-50 correction with normal plasma. That is, we repeat the APTT by adding half by adding normal plasma to that sample. So half and half normal plasma and patient plasma mixed together, and the APTT is repeated. By this, what we do is we add any deficient factor to that sample. So that when it's added, if it was a factor deficiency, it should be corrected. Okay, do you understand? So suppose this sample did not have factor 8. When the normal plasma is added, factor 8 will be present in that sample when the APTT is done. And now if the APTT was prolonged, say it was 80 seconds, now it will come back to its normal level. Okay, so that was done and it was corrected. So which confirmed that this was a factor deficiency. And then the next step is to either you can directly go if facilities are available and do factor levels, or before that you can again do 50-50 correction with factor deficient plasma. There are certain plasma called factor deficient plasma, 8 deficient plasma, 9 deficient plasma. So when they are added, say 8 deficient plasma is deficient in 8, but it contains all other factors. So if it was not corrected by adding 8 deficient plasma and performing APTT, the problem is in the patient plasma does not have factor 8. So it just confirms that. So same with factor 9 deficient plasma. And then the next step is to do a factor assay. So this child factor assay was done and factor 8 level was 0.4%, which confirms that the child has severe hemophilia A. So a few words about hemophilia. It's an X-linked congenital bleeding disorder caused by a deficiency of coagulation factor 8 in hemophilia A or factor 9 in hemophilia B. Estimated frequency is approximately 1 in 10,000 births. And hemophilia A is more common than hemophilia B, representing 80 to 85% of the total hemophilia population. The deficiency is the result of mutations in the respective factor 8 and factor 9 genes. And in about 2/3 of the patients, there is a family history of hemophilia, but in 1/3, it is due to new mutations, and we cannot find a family history in these patients. So in 1/3, there is no family history. So they can present with symptoms of, these are the symptoms. If there's head bleeds, intracranial bleeds, they can present with headache, drowsiness, or nausea, vomiting, or seizures. When there's joint bleed, there is like tingling sensation of a joint just before the bleed. It's called an aura. And then after the bleed, there's pain, tenderness, swelling, warmth, and difficulty in moving the joint. Then there's abdominal bleeds can present with hematemesis, melena, abdominal pain, and then soft tissue bleeds. You can see bruising or mild swelling. They can also present with Swiss hematomas is another common presentation where the legs are kept flexed because the extending is very painful. So the severity of hemophilia is categorized as severe, moderate, and mild. If it is when the clotting factor level is less than 1%, it's severe. 1 to 5% moderate. 5 to 40% is mild. So hemophilia management, the key components of management are prevention of bleeding and joint damage. Especially the joints are the main problem in hemophilia. When there's bleeding into the joint, the blood in the joint is very toxic to the joint, and it can cause, with repeated bleeding, can cause irreversible damage to the synovial cavity. And so prevention is a key component in hemophilia care. Then when there is bleeding, prompt management of the episode, and that management is called price, like giving products, rest the joint, keep ice, compression, and elevation. And then physiotherapy and rehabilitation is also a major component. Then pain management, management of musculoskeletal complications, and then another complication of hemophilia is occurrence of inhibitors. So prevention and management of inhibitors, management of other comorbidities when the children grow older, dental care and psychosocial support, then later on in life, genetic counseling and support and education of the caregivers. So for painkillers, NSAIDs are usually avoided because of the risk of bleeding. But COX-2 inhibitors can be given. So these are the drugs that can be given for pain management, like paracetamol, codeine, and tramadol, or when there's severe pain, morphine is used. So the agents that are used for treatment is for mild hemophilia, tranexamic acid can be used, or DDAVP, just desmopressin. For others, factor replacement is required. We have plasma-derived factors or recombinant factors. Have you seen any patients being treated? Any hemophilia patient? Actually, recently there was a patient in Board 1. Have you seen that patient?
Yes, madam, there was a patient.
There was a patient, no? Right.
Yeah.
Right, okay. So recombinant, so we have both with us, and we also have the standard half-life and extended half-life products. So these can be used. Now we all use FFP or cryoprecipitate, but when the factor, standard factor concentrates are not available, these can be used, but it's very difficult to achieve higher levels with FFP alone, with these factors alone. And then we also have a thing called bypassing agents, which are usually used when there are inhibitors. These are recombinant factor 7A or APCC, or it's also called FIBA, factor 8 inhibitor bypassing agent. Now, the newest drug available for hemophilia care is called emicizumab, which is used for our patients. There's a slide on emicizumab. Yes, so emicizumab is a factor 8 mimetic. Factor 8 is a cofactor for activation, acts as a cofactor for the activation of factor 10 by factor 9. So it just puts factor 10 and factor 9 together. So the same thing is done by emicizumab. It's a bispecific antibody which binds to both factor 10 and 9. And it activates it. So it is the benefits of emicizumab. It is a subcutaneously. It can be administered subcutaneously, whereas all the other products have to be given intravenously. So this is subcut injection, and it has a long half-life. So it can be given like once in 2 weeks or once a month. It has high efficacy in bleed prevention, and it reduces the frequency of bleeding. And it can be given for prevention of bleeding and also for patients with factor 8 inhibitors. But it is not used, it cannot be used to manage acute bleeding episodes. So when you're it is just to prevent bleeding. When there is breakthrough bleeding, it has to be managed like in other instances with factor replacement. So the complications that can happen in hemophilia are chronic arthropathy, synovitis, pseudotumors, development of inhibitors, as I said before, and also psychological impact is very important because this is a very chronic disease, and it affects your daily routines, especially in children. So it has a quite a big psychosocial impact. So that has to also had to be dealt with when managing patients with hemophilia. I think this is the last slide. So I was talking about inhibitors. Inhibitors is a major, it's a very important and troublesome complication that occurs when managing patients with hemophilia. Inhibitors are antibodies that are produced against the deficient factor. Now, say it's a hemophilia A patient, does not have factor 8 or have very low factor 8. So when we give factor 8 from outside, it's a foreign protein to the patient. So with repeated exposures, the patient's body develops antibodies against the factor 8. So then they become very resistant to treatment. Bleeding episodes does not necessarily increase, but the problem is the response to treatment goes down. So therefore, they cannot be managed with a factor replacement. Then we have to use some other means, and that is, one is using factor bypassing agents like NOVO7 or factor 7A or activated prothrombin complex concentrate, which bypasses that pathway where the factor 8 is required and forms the clot. Or the other new thing is emicizumab. So these are management of inhibitors, but removal of inhibitors is by a thing called immune tolerance induction. That, of course, takes a long time. That is by creating tolerance of the foreign protein. That is by giving factor 8 in large doses very frequently, about like 3 times a week. Giving, if in hemophilia A with inhibitors, you give factor 8 but in large dose, like 100% correction frequently. So by that you just try to create tolerance within the body. So that is called immune tolerance induction. Okay, right. But the bleeding episodes have to be, that and the emicizumab may be used for that. But the bleeding episodes have to be managed by either 7A or FIBA or activated PCC. Okay, so I think I just rushed to finish by 1 hour. I think otherwise we'll be really bored. So that's all. You have any questions? I can answer any questions if you have any. Yes,
madam, regarding the patient who was in the ward, madam, with hemophilia B.
Okay.
That patient, madam, the patient was not being given prophylactic factor 9 administration or anything, madam, but within the last 1 year, there were about 17 admissions for factor 9, madam. How do we decide whether we need to give patient prophylactic or how, like, if it is might be given? Yes.
Now, the prophylaxis, there's like primary prophylaxis, secondary, tertiary. There are several ways. But one thing, the main focus is to prevent permanent damage, especially to joints. So if the patient is having recurrent bleeds, usually start on prophylaxis. It's just by patient, depending on the patient bleeds. So if the patient is having recurrent bleeds, we start, and if patient is having severe bleeds like intracranial bleed, again that is a reason to start on prophylactic treatment. Does that answer your question?
Yes, madam. Just a small addition to that question. Is the prophylactic treatment also the same as the one which we give in the
not the same dose, right? Prophylaxis is given more frequently. The ideal thing is to be given like about twice or thrice a week, but that is not practically feasible when if patients are doing it by themselves at home. Now home treatment is still not very well established here. Patients are not very, still we couldn't go to that level. But when they have to come to get the treatment, it's difficult for them to come several times a week. So we usually give once a week. But there again, the dose is very small. We give a small dose. like, about a 20-30% of correction. The aim is to change the moderate hemophilia, the severe hemophilia to a moderate hemophilia, not to correct the total deficit. So when you raise the factor level from severe level to a moderate level and try to keep that throughout, so that they will not have spontaneous bleeds.
Thank you very much.
Yeah. Is there are questions? Someone has asked, child develops factor inhibitors, what is the management option? I think I have answered it now. So if you have inhibitors, you have to manage the acute bleeds, we have to use bypassing agents like PCC or factor 7A. But to prevent bleeds, we can use emicizumab. And to take away the inhibitors, we can try immune tolerance induction. And here there's another question before that. What is the importance of doing LDH levels? LDH, that is in the anemia. LDH increases when there's hemolysis. It's a very good indicator of active hemolysis. All right. Do you have any more questions? All right. Did you understand?
All right, madam. Thank you for the class.
Okay. Okay. Then. Okay. Okay. Thank you. Okay. Bye. Okay.
Thank you very much, madam.
I think you'll have to end it now.